And good afternoon, everybody. 1 second while I get my slides up. I'm actually glad to be the last one on the session. Thank you for saving time for me. I want to move us now to talk about a little bit of a different approach to early ANC attendance. And it's been mentioned a couple of times by some of the other presenters here. And I'll present some early results from the ACCLAIM study, which is being done by EGPAF. First of all, disclosure that this work is funded by the Canadian government, the Department of Foreign Affairs, Trade and Development Canada, and we're very grateful for their support. As background to this, PMTCT programming at facility level has not been effective in addressing the community level barriers that affect demand. And particularly what we've heard here today is the issue of early ANC. Has not been able to be addressed. Once women already come late, you can't make them come earlier. In the literature, there's very little evidence of successful community interventions that address demand and uptake of PMTCT. And we hypothesize that PMTCT performance could be improved with innovative interventions that address community norms, including harmful gender norms, barriers to positive health behaviors, and health-seeking behaviors for all women. And as we look towards successful implementation of Option B+, and with test and treat on the horizons, we know that we urgently need new approaches to community engagement. With this in mind, we designed the ACCLAIM project, which stands for Advancing Community-Level Action in Maternal and Child Health in PMTCT. The goal of the project is to increase community demand, uptake, and retention in MCH and PMTCT services towards elimination of pediatric HIV. This is a cluster randomized trial with 45 population clusters in Uganda, Zimbabwe, and Swaziland, 15 clusters in each country. The intervention period is over 8 months. This project in the community operates on 3 different levels. First is the level of leadership with community leaders who are empowered and take action in the community. There is a community members level which opens the public dialogue to discuss some of the norms and issues related to MCH and PMTCT, and then on an individual level to provide information to change people's attitudes. This is the study design. There are 3 arms. Each of the arms, as you can see, has the community leader engagement intervention, and then we have the 3 arms to be able to compare the effects of the different combination of interventions in the project. The primary endpoint is attendance at the early infant diagnosis visit at 6 to 8 weeks of age. The secondary endpoints are listed here. I'm going to talk about the first one today, which is ANC attendance before 20 weeks. And one of the reasons to look at this particular endpoint is that's the first one where we would expect to see any change from the community intervention, is that first ANC visit. The community leader engagement intervention, we have leaders chosen by each community in the 45 clusters. They go through a 5-day Community Leader Institute, which provides them with knowledge and information on maternal and child health, PMTCT, and builds skills in community advocacy and planning. The leaders use maternal and child health and PMTCT data from their community to develop community action plans with other community stakeholders to address the barriers that they see in their communities. They also use community dialogues and meetings to conduct advocacy with some of the key messages, including encouraging families to protect the lives of the mother and the child, and emphasizing early ANC visits and facility delivery. At baseline, we did a community study, a knowledge, attitude, practices, and behavior study, and we found that the community was aware of the need for early ANC, as is in the first column here, with the highest levels being 41%, agreeing that a woman should go to ANC as soon as she realizes she was pregnant. However, the actual practice that we found in the facility level data told a different story. With ANC attendance before 12 weeks gestation, the highest was in Uganda at 16%, and you can see Zimbabwe was way down at 3%. And as other people have said about women generally coming to ANC late, the average gestational age at the first visit was between 20 and 24 weeks, which is quite the norm across the region. For this study, each ACCLAIM cluster includes a health facility that provides ANC and PMTCT services. The data on gestational age at first ANC were collected retrospectively from the ANC registers in the health facilities. The health workers estimate gestational age by palpation in the region, and any pregnancies that were too small to palpate were coded in this study as being at 10 weeks gestational age. Baseline data were collected for the quarter prior to when the interventions began, and we compared them to 1 year later. And we are going to present the results for all 45 clusters who have implemented so far the community leader engagement intervention. For the indicator of women attending ANC before 20 weeks, overall this increased from 45% of the women to 51% of the women, and this was significant across the 3 countries. We then looked at the trend in mean gestational age when we saw this, and overall the attendance at ANC has fallen by 2 weeks, and this is significant in Zimbabwe and Uganda, but not in Swaziland, which started at a bit of a lower level anyway. We looked next at very early ANC attendance, which we characterize as at or before 12 weeks gestational age, and looked at the trend over time for the study. You'll notice here that the interventions began in Uganda a bit later than they did in the other 2 countries, and that's why the line has shifted. But you can see in the graph that the trend is smooth. There are no seasonal variations that we would see here, and the majority of the changes actually happen in Zimbabwe. And we looked at some of the reason for this to try to understand Zimbabwe. And in this study, we're also collecting very careful data on the exposure to the interventions. And we know from these data that the exposures in Zimbabwe from the community leaders have been extremely high. They were extremely enthusiastic about the project, and they have conducted thousands and thousands of meetings and dialogues in their communities. So in some ways it's not surprising that we're seeing this trend in Zimbabwe, but I know that there are other factors as well, because this is a community study and we live in a world with a lot of things happening. One of those things that's happening is in the middle of this study in Zimbabwe, they have scaled up option B+. And so we wanted to look at this a little bit more to see how much of what we're seeing in Zimbabwe was due to B+, and how much we might be able to attribute to our interventions. We used the electronic database in Zimbabwe, which collects routine data from some large volume sites, none of which are in the ACCLAIM areas. And so we compared the number of women attending ANC before 20 weeks or 12 weeks in those sites with the ACCLAIM study. So the top 2 lines are the attendance before 20 weeks, and the bottom 2 lines are the attendance before 12 weeks, with the area shaded in the middle, the period of option B plus scale up. So you can see that option B plus has improved earlier ANC attendance to some degree, but that in the ACCLAIM sites, this increase is much more rapid. So in conclusion, these are preliminary results. They suggest that our community leader training and engagement is associated with a positive trend toward earlier first ANC attendance, and further results from this study will track progress on the study outcomes as we roll out the remaining interventions and have a longer period of exposure with which to assess the results. I'd like to acknowledge all the country teams in Swaziland, Uganda, and Zimbabwe, our community leaders and peer facilitators, and our donors from the Canadian government. Thank you very much.